This topic is very huge, just like this iceberg in the Antarctica, but I'll try to do justice within the short time allocated. When we look at cardiohepatic interactions, you are looking at three different things. Firstly, primary heart diseases that can affect the liver, that may be the ones that we are quite familiar with. Or, on the other hand, primary liver diseases that affect the heart secondarily. And then there are diseases that may affect either organ simultaneously, but not necessarily in a kind of equal manner. To understand the effects of the heart on the liver, one needs to understand the basic anatomy of the liver. The basic unit is the liver lobule, which is a roughly hexagonal structure with a central vein in the middle with a portal triad at the vertices, at the corners. At the portal triad, there's the portal venule, the hepatic arteriole, and the bile ductules. And the liver gets the blood through the portal venules and the hepatic arterioles, and the blood from these mixed together within the sinusoids, draining back to the central vein, which in turn drains to the hepatic veins. The hepatic veins themselves don't have any valves, so as a result, any increased pressure in the IVC is directly transmitted to the liver. Now, when you have any heart disease, the effect on the areas, the centrilobular areas versus the other areas would depend on where the insult is coming from. So if you look at the reduced perfusion, which will be from the hepatic arteriole side, it will be worse felt around the central vein. So there is more centrilobular necrosis. Same thing happens with congestion. If there's congestion coming through the IVC to the hepatic vein to the central vein, the brunt of the insult again would be within this centrilobular area. So that area is more damaged in heart diseases. When one looks at heart diseases affecting the liver, there are clinical syndromes. First is the acute heart failure, where there's primarily acute hypoperfusion, which can lead to what is kind of called ischemic hepatitis, shock liver, or the new term acute cardiogenic liver injury. Chronic heart failure, on the other hand, the primary problem may be the passive congestion, which in turn leads to what we would term as nutmeg liver or ultimately cardiac cirrhosis. Obviously, you could have chronic heart failure, then an acute insult like a big infarct could occur on a patient with chronic heart failure, leading to a combination of both. So often there's kind of both these forward and backward factors often coexisting. Acute cardiogenic liver injury, it's usually seen in patients with a cardiac arrest or acute severe heart failure with cardiogenic shock. And the acute ischemia leads to a transaminitis. And any hypoperfusion effect would be amplified by any concomitant hypoxia due to pulmonary edema if oxygenation can't be maintained. From a clinical point of view, majority may remain asymptomatic and you'd see the liver function abnormalities, although it can go to further stages of resembling a viral hepatitis or even acute fulminant liver failure. There are rare cases where the cardiac etiology may not be apparent and missed. Somebody who's collapsed at home, resuscitated much later, and they come into hospital, and as you do the test, the first abnormalities are the transaminases having gone up to the thousands, and you think the primary problem was in the liver. The histology is necrosis, and as I said, surrounding the central hepatic veins, which is zone 3. And obviously, if the hypoperfusion persists, then the necrosis will extend to the middle areas and ultimately to the portal triad areas. So clinically, what do we see? It's typically a rise in ALT and AST followed by a rapid decline if the failure can be dealt with. important point is the lactase dehydrogenase increases in parallel with the transaminases, and this can help to differentiate from acute viral and drug-induced hepatitis where LD doesn't go up very much. And you can actually do a ALT to LD ratio of less than 1.5 would suggest that it is hypoperfusion related liver damage as opposed to other primary liver problem concomitantly occurring with heart failure. Jaundice, on the other hand, is seldom severe unless there is acute liver failure which has gone to a much more severe degree. And generally speaking, if you have acute fulminant liver failure secondary to acute hypoperfusion, acute heart failure, the prognosis appears to be better than if the fulminant liver failure was related to a viral hepatitis or primary liver cause. And once the underlying problem is dealt with, survival approaches 70%, which is much better than average for a primary acute liver failure. What are the risk factors for mortality in somebody who's coming in with heart failure with high ALT values and so on? So if they have any significant degree of encephalopathy, or on the other hand, if their PTINR is greater than 2, those are bad prognostic features. Now, traditionally, the liver injury related to acute heart failure was thought to be related to the low cardiac output, because the liver gets a lot of cardiac output, and obviously the cardiac output is reduced when there's acute hypoperfusion. The study by Henrion looked at two groups of patients. Both had low cardiac output, denoted LCO, and HH denotes hypoxic hepatitis. So they compared the two groups, the group who had low cardiac output without any hypoxic hepatitis versus the ones who had concomitant hypoxic hepatitis. As you can see, the majority of the parameters were not much different between the two groups: the gender, the age, the previous history of heart failure, the occurrence of the acute event, the duration of shock, cardiac output, blood lactate levels, and so on. The only significant difference between the two groups was really the central venous pressure, which was 14 centimeters mean in the group without any hypoxic hepatitis versus 22 centimeters mean. In the same study, they looked at a third group, which was called controls, but that is a group where there was shock related to trauma, so basically hypovolemic shock without any primary cardiac problems. And they looked at the three groups to see the effective hepatic blood flow. And so what they found was that the effective hepatic blood flow had a gradation from the people with hypovolemic shock to the people with a low cardiac output without any hypoxic hepatitis to the people who had low cardiac output with hypoxic hepatitis. But as you can see, there are certainly outliers. But I think the conclusion was that for liver injury to occur acutely from acute heart failure, there has to be concomitant hepatic congestion, so that 2 hits are required to produce this injury to the liver. So if the right heart pressures were normal, then the chance of liver injury are much less. Just a caveat, liver injury is increased in anybody who has a fatty liver, and fatty liver itself is quite frequent in patients with heart failure because of the comorbid conditions, diabetes, obesity, dyslipidemia, and so on. Given the fact that the obesity is increasing and fatty liver has been increasing in prevalence, one would expect to see more adverse liver effects from heart failure in the future. What about the treatment? Treatment is primarily to try and augment the perfusion, from the cardiac point of view. So obviously in the acute setting, if there's shock due to an infarct, correct the cardiac ischemia, acute aortic regurgitation, go for urgent valve surgery, inotropic agents, to tied to a more definitive procedure, and obviously left ventricular assist devices may need to be used. Blood transfusions, as you know, a recent study indicated the people who have been using blood transfusions in the setting of anemia in the patients with cardiac disease, they tended to improve. Diuresis, as I said, both mechanisms are have to be there to produce the liver injury. So diurese and reduce the central venous pressure and consider ultrafiltration if needed. And if the intra-abdominal pressures are high, again this will make matters worse as far as the effective hepatic blood flow is concerned. And if the ascites is significant, one could look at paracentesis. It's not very common early on to have any significant ascites in this group. The second group that we are looking at would be the chronic passive congestion due to chronic heart failure. So predominantly, this is a right heart failure problem, which obviously could be secondary to left heart failure, which is biventricular failure. On the other hand, one could have severe tricuspid regurg, constrictive pericarditis, restrictive pericarditis, and so on. So the primary problem here is the increased hepatic venous pressure. And as I said, as there are no valves in the hepatic veins, this is directly transmitted to the sinusoids. And so what happens there? There's obviously increased lymph formation because of the increased pressures within the sinusoids. There can be bile ductular damage because the bile ductule is basically in between the hepatocytes adjacent to the sinusoid. And then the stagnant flow within the sinusoids as well as in the hepatic venules can lead to thrombosis there, and that can in turn lead to fibrosis. So this may explain that in cardiac cirrhosis, the fibrosis can be patchy early on as opposed to other conditions, because the fibrosis may be secondary to thrombosis occurring sporadically. In addition to the hepatic increased hepatic venous pressure, there is, depending on the cardiac output, there could be decreased hepatic blood flow as well, which would again make matters worse. And then you have decreased oxygen saturation. So ultimately, when you look at the acute hypoperfusion affecting the liver versus chronic hypoperfusion, there's a lot of overlap, both on the supply side as well as increased venous pressure side. Again, you have centrilobular necrosis. Cirrhosis is generally rare unless the cardiac failure has been going on for many, many months to years kind of thing. So these days to see cirrhosis is generally rare because of the treatment that we can give these people. Now, clinically, they can be asymptomatic, or on the other hand, some of these people can present like an acute abdomen, and people have had operations of the gallbladder thinking it's cholecystitis, or somebody thought that they had acute viral hepatitis in this setting, because the predominant feature may be the right upper quadrant to epigastric pain rather than primary forward heart failure. This study looked at these patients from the CHARM study, looking at people who had chronic heart failure, to see what effects did the heart failure have on liver parameters, biochemical parameters, and then what did the abnormalities in the biochemical parameters have on the prognosis. So firstly, what they showed was that the ALT increase was much less compared to the acute hypoperfusion state. So it was much more likely that the bilirubin, the alkaline phosphatase, and the albumin were abnormal in this group. Furthermore, they also showed that there was a big difference in the people who had future events in terms of cardiovascular death or heart failure. They had a much higher likelihood of abnormalities with the alkaline phosphatase, albumin, and bilirubin compared to the ones who didn't have an event. And the corollary was that the higher the levels abnormalities in these tests, more likely you had future events. So basically, one could look at, when you have a heart failure patient, to do their liver function panel, and just like using the creatinine as a guide to future prognosis, these could be used as a good guide as well. In congestive hepatopathy, varices tends to be generally rare. That is because the varices are portosystemic shunts, and they only occur when the hepatic venous pressure gradient, which is basically the portal venous pressure minus the CVP, is greater than 10 millimeters. In congestive hepatopathy, both kind of go up together, so as a result, the gradient is not higher. So they don't generally get varices until they develop advanced cirrhosis, and generally advanced cirrhosis, as said, doesn't occur too much these days because of the earlier treatment with heart failure, although it can occur, conditions like constrictive pericarditis and so on, which could be missed for years and years and years. Obviously, they will get all the other non-portosystemic complications of cirrhosis. Treatment again is the treatment of the heart failure and treating the congestion, maintaining the euvolemia. People who have chronic ongoing heart failure, generally the chronic passive congestion in the liver improves after heart transplant. And then, other modalities like assist devices and so on can be used as well. But from a practical point, it is important not to underestimate the prognostic values of the liver function tests in chronic heart failure. Next, getting on to the liver diseases affecting the heart, you have three syndromes. The hepatopulmonary syndrome is one where there are unknown factors causing pulmonary vascular dilatations. Then there's portopulmonary hypertension, where unknown factors are causing pulmonary vasoconstriction and thus increased pressures in the lungs. And thirdly, there is the cirrhotic cardiomyopathy, which is a LV systolic dysfunction due to the inability of the diseased liver to remove potential toxins, or portosystemic shunts, obviously bringing in more toxic materials to the heart, bypassing the liver. However, dyspnea in patients with cirrhosis has a much kind of broader differential diagnosis. It could be simply due to elevated diaphragm from tense ascites. It could be to what we call hepatic hydrothorax or hepatic hydropericardium. Or on the other hand, it could be due to these three syndromes of portopulmonary hypertension, hepatopulmonary syndrome, or cirrhotic cardiomyopathy, and obviously they could have concomitant unrelated heart failure as well. What is hepatic hydrothorax? Basically, it is an accumulation of the acidic fluid preferentially in the thorax compared to the intra-abdominal area. This is due to the direct communications between the pleural and peritoneal spaces due to the known anatomic defects in the tendinous portion of the hemidiaphragms. There's unidirectional flow due to the negative intrathoracic pressure. So as a result, you may have large pleural effusion but no ascites, thinking, misdirecting you to a problem with the lung as opposed to the liver. 85% tends to be right-sided, and this can occur in about 5 to 10% of the patients. It's defined as an accumulation of around 500 ml of fluid. Just like spontaneous bacterial peritonitis, you can get spontaneous bacterial empyema because this is the acidic fluid with possible bacterial toxins, bacteria getting in from the gut to the acidic fluid and then to the thorax. And this can occur in about 15% of the patient and has a fairly high mortality. How do you diagnose it? It's by intraperitoneal injection of technetium labeled colloid or albumin, and then finding that that has gone through the diaphragm back onto the chest cavity. You may end up having to do diagnostic thoracentesis, CT chest, and so on to rule out other primary causes. Treatment-wise, treatment of the volume overload, basically like trying to get rid of the acidic fluid if it was in the abdomen alone, may help. Liver transplantation or TIPS both tend to help to get rid of the fluid. And then you can do therapeutic thoracentesis as well as a temporary measure, but it is known that chest tubes have been associated with a much higher mortality risk, presumably because of the chance of infection and so on, and it is not recommended. On patients who do not have any other definitive forms of treatment, you can look at thoracoscopic repair of the defects or pleurodesis and so on. Hepatic kind of hydropericardium is also a similar thing, where there's a direct communication between the peritoneum and the pericardium, and again can occur without ascites. And this can be associated with HCV and cryoglobulinemia infections, or with HCV or cryoglobulinemia. Treatment is similar. Now, portopulmonary hypertension is essentially a type 1 pulmonary arterial hypertension occurring in patients with cirrhosis. So the mean pulmonary artery pressure is greater than 25 millimeters with the wedge pressure which is not high. They must have portal hypertension, and there's no alternative cause found for the pulmonary arterial hypertension. Prevalence, about 5 to 10% of liver transplant candidates have portopulmonary hypertension. Exact cause is not known. Two potential factors: there appears to be a genetic predisposition, as is the case with primary pulmonary arterial hypertension, and there may be substances that are metabolized by the liver that reach the pulmonary circulation, causing due to the portosystemic collaterals, because it usually occurs only with portal hypertension. And it's not due to a hyperdynamic state like the cirrhotic cardiomyopathy, and also not believed to be due to any thromboembolic events that can occur from the portal system to the lungs. It tends to definitely adversely affect survival. So this graph shows the survival in people with portopulmonary hypertension. So what is known is the ones who don't get any treatment have the worst survival, but treatment of either the pulmonary hypertension part or the liver by liver transplant both don't tend to help the survival that much. Concomitant treatment of both these conditions are needed to really benefit survival over time. We assess it by obviously right heart cath, as the echo can be misleading sometimes in a hyperdynamic state in terms of measuring pressures. And you have to confirm the presence of pulmonary hypertension and also exclude other causes of elevated pulmonary capillary wedge pressures, as well as other causes of pulmonary hypertension. If the pulmonary hypertension is mild, with a mean pulmonary pressure between 25 to 34, they tend to generally do well, not a contraindication to liver transplant. On the other hand, if the pulmonary pressures are in the moderate range, it's associated with a 50% mortality post-transplant, so they definitely need further workup regarding reversibility prior to transplant. Very high pulmonary pressures, if it has gone to that level, then the transplant may not affect the prognosis at all. The last syndrome from the liver's point of view is the hepatopulmonary syndrome. This is due to two issues. Either you have pulmonary AV malformations or pulmonary vascular dilatations. So you have symptoms of hypoxia and also platypnea, where you have dyspnea more in the upright position as opposed to supine, with changes in the oxygenation as well. Exact pathophysiology again is not known. It could either be an unknown factor that is normally cleared by the liver coming from the gut, causing pulmonary vasodilatation, or on the other hand, it could be a hepatic factor that is actually a vasoconstrictor that has reduced production in liver dysfunction. This is the reason why this condition can occur in patients with congenital heart disease, where surgeries where the venous circulation has bypassed the lung. So obviously any substance that is coming from the liver that is toxic cannot get into the lung because the venous circulation is going past the lung now. Nitric oxide is believed to be a key factor causing vasodilatation, nitric oxide being produced by endotoxins and then further aggravated by hypoxia. Hypoxia itself has two mechanisms. You can have a diffusion limitation or a true shunt. It generally doesn't cause any right ventricular failure because the total shunt is less than 1.5 to 1. and occurs mainly in chronic liver disease, but occasionally occur in acute liver failure. And generally, the severity is not necessarily correlated to the severity of the liver dysfunction. So in the normal lung, there is the venous blood coming through, getting into the alveoli with oxygenation. So in the bottom panel, first of all, you can have a arteriole just bypassing the alveolus completely, causing true shunting. On the other hand, you can have vasodilatations where the increased blood flow there makes it difficult for the alveolus to oxygenate all the blood because there's too much blood going through that one segment. Diagnosis-wise, it requires portal hypertension, and you have impaired oxygenation. In terms of diagnosing the intrapulmonary vascular abnormalities, you can do agitated saline injection where you will see late crossing of the bubbles. If it's a true intracardiac shunt, the bubbles will cross very early. Here, 3 to 6 cardiac cycles later, you will see the crossings. And you can do a pulmonary angiogram, obviously, if you're looking for AV malformation. Treatment-wise, no real medical treatments are available. If there's severe hypoxemia, you may be able to embolize a pulmonary AV malformation if there are large ones found. Obviously, you will want to ensure arterial precautions for venous lines, and this is considered an expedited indication for transplant. That's because if you look at the people with hepatopulmonary syndrome without any transplantation has a really dismal prognosis, much worse than people with liver failure without any hepatopulmonary syndrome, which is the next slide. So if you do transplant in hepatopulmonary syndrome, the improvement in prognosis is far greater than if there was no hepatopulmonary syndrome in the setting of liver failure. So transplanting early in this group is the way to go. Now lastly, there is the cirrhotic cardiomyopathy. Just to illustrate a case, this is a 40-year-old lady with end-stage liver disease. On a pre-transplant echocardiogram, ejection fraction is greater than 60% with mild diastolic dysfunction with a EA ratio that's reversed. It's deemed acceptable for transplant. However, after the transplant, day 3, there is acute decompensation with a repeat echo showing an ejection fraction of like 10 to 15% with severe global hypokinesis, with death following shortly thereafter. So basically, this condition can present the post-liver transplant, post-paracentesis circulatory dysfunction, or post-TIPS insertion. So as a acute stress precipitating the heart failure. And so the thing is, some of the tests that we do to look at heart function in a hyperdynamic state may not necessarily detect this. So it's basically a hyperdynamic unloaded failure of the heart, like a high output state, where because of the low systemic vascular resistance, the ejection fraction is maintained in the presence of dysfunction in the heart muscle. Cardiac pressures can be normal at rest, although with stress they can become abnormal. The diastolic dysfunction is a clue here. There is increased stiffness of the myocardial walls with eccentric hypertrophy, and diastolic dysfunction is commonly found. And so if you see a patient when you're doing echocardiograms in possible liver transplant patients, pay kind of more attention to diastolic dysfunction and report on that, because that's an indication of something going wrong, something that may go wrong after the transplant. Diastolic dysfunction itself has been associated with poor prognosis. There are a whole host of other abnormalities like chronotropic incompetence, QT prolongation, resting tachycardia, and so on, which can be there in this group of people. Treatment-wise, do not discount any diastolic dysfunction in this group. Inotropes in this setting may have a blunted response due to the beta receptor downregulation. And the in the post-paracentesis circulatory dysfunction, replacing volume may help. In systolic dysfunction, their standard heart failure treatment, again, carvedilol appears to be superior in many settings, as was mentioned previously as well, in terms of improvement compared to other beta blockers. And some of these people can have left ventricular outflow tract obstruction, simulating a hypertrophic cardiomyopathy type of picture as well. But generally, if the patient can be gotten through the acute period, the cirrhotic cardiomyopathy improves substantially. So I'll end there with this photograph again from the Antarctica. Thank you.